Good afternoon, everyone. Thank you for joining us on our webinar session today. Our webinar session today is on abdominal surgical emergencies in children. And our webinar will start with I'll be introducing a few words about Yetenaweg, then I'll say a few words about our guest speaker, and then I'll leave the floor for him. My name is Menelik, and we have other members of Yetenaweg volunteers here on the background co-hosting the webinar. So Yetenaweg is a volunteer network digital platform. It's registered in Pennsylvania, US as a nonprofit organization, and it's run entirely by volunteer members. We currently have 70 active volunteer members across 5 countries and counting more, and just started with 3 active members. We have different projects under Yetenaweg. One would be health promotion. Under health promotion, we have discussions and articles regarding health of the general public and health policy and implementation. The other one is a community engagement, where blood drive, inclusive equity projects, and fundraising campaigns are prepared. And we also have a mentorship and skill sharing program. Under this, we have direct mentorship of soft skills and career development, and we also have career and development career and professional development webinars. And we also have another project with the medical education project, which is the one preparing this continuous medical educations, and also research and KY projects. So these pictures are pictures depicting different events where volunteers participated, and also doing different activities, including blood drive and also donations. As this is just to say, Yetenaweg is more than a digital platform. Yetenaweg, along with ROHA, had the 3rd round of health article writing competition organized in collaboration with Ethiopian Medical Students Association. ROHA Medical Campus will awarded travel grants for 2 health article writing competition winners of the 2022 and 2023 overall winners. And also Yetenaweg also awarded pulse oximetry for top 20 winners and Bismarck stethoscope for top 30 winners, and top 5 winners also got internship opportunity at ROHA and other partner institutions. These pictures are also winners of our 2021 and 2022 and 2023. Yetenaweg with ROHA again has a research fellowship. It started on March 14th, and research grants where we had 3 research grant winners. 2 were from 3 different departments. 2 were from internal medicine and radiology and oncology department mentorships. And we also had mentorships for 10 winners. So our continuous medical education is freely accessible. We had 30 CME webinars so far, and average webinar attendees were around 150 to 200 healthcare professionals. And in 2024, we plan on around 30 webinars focusing on emergency surgical medical cases, ENT, pediatrics, obstetrics and gynecology, and oncology cases. Yetenaweg partners with Ethiopian Medical Association, Ethiopian Society of Cardiac Professionals, Ethiopian Society of Internal Medicine to provide this continued training for healthcare professionals. Our today's partner is Ethiopian Medical Association. Thank you. And we invite renowned local and international speakers. So if you ever wonder where you can access our previous CME sessions, you can check it on our Yetenaweg YouTube channel. And if you want to keep posted and get updates on the upcoming CMEs, we highly suggest you join our Yetenaweg Telegram channel for healthcare professionals and follow our social media posts on Twitter, Facebook, LinkedIn, and Instagram. So for brief experience in this webinar, you can send questions on the Q&A and chat box. At the end of the webinar, they will be addressed by our guest speaker. And also you'll have a chance to ask the speaker directly if you raise your hand. To get your CEU certificates, attendees must fulfill the following 3 criteria. One is to attend the whole session virtually, and minutes attended will be checked by Zoom attendee reports. The second one is to fill Google form for personal details and attendances. And the third one is get 50% and above on the post-webinar quiz. The post-webinar quiz link will be sent on the chat box once the webinar is over, and then you'll get your results right away. But the certificates will take 1 to 2 weeks to be delivered on your email, so we kindly ask you to wait for it patiently. Thank you. After saying this, I'll just say a few words about Dr. Samuel Negash, who's our guest speaker today. Thank you, Dr. Samuel, for joining us. Dr. Samuel is a consultant pediatric surgeon and assistant professor of surgery based in Ethiopia. He obtained his medical degree and completed his residency in pediatric surgery at Addis Ababa University. His clinical practice is primarily based at Menelik Second Hospital and Breast Generalized Hospital. Dr. Samuel is actively engaged in academic activities, training students from AAU and Sante Medical College. He has a keen interest in global surgery evident through his certifications, including Global Health Equity Fellowship from University of California, San Francisco, and various research collaborations with Kids OR. His research work primarily focuses on pediatric surgery, with a special interest in improving access to pediatric surgical services in low-income countries. Dr. Samuel has authorized more than 15 publications to date. Furthermore, he collaborates with different local and international NGOs international NGOs on various global health projects. His notable affiliations is with Lifebox Foundation, where he works as a trainer and research associate, and with local NGO Help Ethiopia, where he serves as a program manager. Dr. Samuel's experience extends to his proficiency in delivering lectures and sharing his knowledge with others. So he's here with us to share his knowledge with us today. Thank you for joining us. I'll leave the floor for Dr. Samuel.
Okay, good morning, good afternoon, everyone. Thank you very much for the kind introduction. And I would also like to thank Yetena for creating this platform to have this training. So the topic for today is abdominal surgical emergencies in children. As you might know, pediatric surgery is a relatively new field in our country, which more emphasis has not been given. So this is actually this presentation, I would like to acknowledge, is taking part of a larger training that we're preparing, pediatric surgery emergency training, with collaborators at University of California, SF, and our local NGO, Help Ethiopia. So I'd like to thank my collaborators on that. So as you might imagine, abdominal surgical emergency is quite a vast topic. But we'll try to focus on some of the important things. And I know on this platform there are many physicians from many specialties and also non-physician and professionals. So we'll try to stick to the basics as much as possible. So the main aim is to highlight about the pediatric emergency surgical conditions, how to recognize them early and treat them early. So this presentation is divided into two parts. On the first part, would focus mainly on how to resuscitate and safely transfer, because most of these patients might need referral to another hospital. We'll see how to safely do that. And on the second part of the presentation, we'll mention some of the common diseases that we have and highlight important points on the management. So beginning with the first part. So as you know, children, they have a volatile physiology, so they can easily decompensate. And preoperative optimization, resuscitation is the most important part, even more important than doing the surgery. You can do a flawless surgery, but if patients are not adequately resuscitated and optimized, you'd lose those patients. So on this part, we're going to be focusing on how do we know how much you should resuscitate. So you should be able to assess resuscitative needs, calculate how much fluid that the patient needs or other things that the patient needs. So the assessment is very crucial. And then you have to be able to administer the appropriate resuscitation. And then on transfer, we'd see some of the complications that can happen during referral of these patients and how to prevent them. So I'll start with this case example. This is an actual patient that I had a couple of years back. So this newborn was born with a spontaneous vaginal delivery at term with a normal birth weight. And immediately after delivery, the physicians noticed that he had bowel eviscerating through the abdomen. So he was immediately sent to our hospital. But since he was from far away, it took around 24 hours to arrive at our hospital. Upon presentation, he was very irritable, he was crying. The vital signs were deranged, was tachycardic, febrile. Although his respiratory condition was relatively okay, did not require oxygen. Further examination, we found he had dry lips and dry buccal mucosa, the capillary refill was okay. And then the bowel, there was some normal bowel, but the bowel on top was gangrenous. So when you have this kind of patients, well, obviously this the diagnosis is obvious, right? This patient has gastroschisis, is one of the congenital abdominal wall defects in which the bowel will flow through like this. So, but now the urgency is not, the life-threatening thing is this child adequately hydrated? So the fluid status, is this child in shock or not? That is the thing that would imminently kill the patient. So in any emergency situation, first you should be able to assess what are the resuscitative needs of the patient. So this is very basic, you all know it. So vital signs are very essential, and you need to look for some signs on the history, on the physical examination. But if you're not particularly, working in pediatrics, if you're not exclusively working with children all the time, it might be difficult to remember what is normal, what is abnormal, because the vital signs vary with age. But this is very important. At least, I think it's best if you memorize the heart rate, at least for the different age groups, because you have to know what is tachycardia, what is bradycardia, and how do we manage these children if they have tachycardia, if they're in shock. So as a general rule, in infants, the heart rate is very high as compared to adults. And gradually, as they grow up, the heart rate will go down, and around 12 years of age, it will reach the adult normal value. In contrast, the blood pressure is low, but gradually it will increase until it reaches the adult value around the adolescence age. So especially the heart rate, like I said, it's important. When do you say the child is tachycardic? So for an infant, we can tolerate around 150, 160 heart rate. Above that, it's what we consider tachycardia. For a toddler, which is from age of 1 to 4 years, up to 120 heart rate might be normal. So above that, we consider the patient is tachycardic. And then up to 12 years, we might consider 110 as a cutoff for tachycardia. So it's always good to have this in mind, because we need to know when the patient needs resuscitation and when the patient is normal, okay? So, but it's not only the tachycardia that worries us. In children also, bradycardia, the cutoff for bradycardia is different, right? Bradycardia means the child is not getting enough oxygen usually, and then the child is going to go into cardiac arrest very soon. So it's essential to pick up bradycardia early and treat it early. So in an adult, you would consider a bradycardia when the heart rate goes below 60, but in children, even a heart rate of 90 might be considered bradycardic. So especially in neonates, uh, less than 110, 100, you should be worried, right? So these are some of the things that you should give emphasis on. Well, the blood pressure, is one of the things that you consider to say shock in a patient, especially in adults. But in pediatric patients, it's difficult to get blood pressure management. Practically, when you come to our setting, it's difficult to get appropriate size blood pressure cuffs and so on. So we mainly rely on heart rate and the other signs. So I'd like to emphasize you should notice normal values. So like I said, you can't miss tachycardia. In children, sometimes tachycardia might be the only sign of shock, and they might be on imminent cardiovascular collapse, and the only sign you might find is tachycardia. So it's very essential uh, in kids. So what about the other signs? The other signs, you might know them. These are signs of dehydration. So patients might be febrile, fontanelles might be sunken. You can see the lips and the mouth, they will be dry. And the general condition of the patient would be lethargic, will not be active. So all these things should consider when you assess the fluid status of the patient. Another important thing that we use in kids is the capillary refill. So the capillary refill, you can press on the finger pads, and then if the refill is more than 2 seconds, you should be worried that this patient is not getting adequate circulation. And urine outputs, well, when the child comes, you cannot measure urine output, but historically, you can ask the parents about the urine output. And also on your physical examination, this is something that you can check on the diaper, whether the diaper is wet or not. So it also gives you a clue about the hydration status of the patient. And another thing that you might notice is this mottling of the skin. So you can see in this picture here, this reticular pattern like discoloration of the skin. So this usually happens in septic shock. when patients have rapidly decreased blood flow to the skin, this kind of discoloration might happen. So all these things would help you support, your assessment of fluid status. But always, I'd like to emphasize, you should also suspect the patient might have this when you have these surgical patients, when you have patients with large amount of fluid loss, when you have these patients with severe infection with sepsis, you should suspect always they might have some sort of hypovolemia, they might need some sort of resuscitation. So all these things would be clues to guide you in that direction. So in this child, what signs did we see? So you can see tachycardic, febrile, he has dry lips and buccal mucosa. So all these signs of dehydration are there. And also you can see the patient has a gangrenous bowel. So this patient can also go into septic shock from this. The bowel is exposed. He might also have evaporative losses from that bowel. So all these things, considering all these things, definitely this child would need resuscitation. So then how do we administer fluids? Obviously, we need an IV access, right? Again, a very simple thing, obtaining IV access, but in children, it can be quite difficult sometimes, especially if it's been attempted too many times. So normally, for the smaller kids, we use, the 24 gauge needle, at least, the yellow one, and for the older kids, we might use the 22 gauge blue needle. And as much as possible, we want to have a peripheral IV access, right? If it's available. So you can see here in this picture the different sites where you might be able to get this peripheral IV. But sometimes it might be difficult, like I said, and so in those desperate situations, sometimes patients would be on the verge of collapse between life and death, and we've been able to resuscitate them through intraosseous lines. And I'd just like to emphasize on the importance of intraosseous lines. Usually people don't think about them because maybe the equipment is not available, but you don't really need that much equipment, especially for the small children. If you have a bone marrow needle, or even for the neonates, if you have a transfusion needle, so a large needle is usually found with the transfusion sets that you have. You can find it at any blood bank in your hospital. So that can be used to puncture the bone. So that would be enable you to administer fluids rapidly and revive the patient. So always you should consider obtaining intraosseous lines in these patients for resuscitation if peripheral IV line is not available. So how do you administer fluids? Well, if it's for resuscitation purposes, you give boluses, right? You're trying to revive the patient. Patient is going into shock. So what we recommend is to give 20 ml of bolus fluid. And the type of fluid, it has to be isotonic fluid. So no, you should not give dextrose-containing fluids like maintenance fluid. It should be normal saline. And then this bolus of fluids can be repeated 2 times, 3 times, depending on the patient's response. And once the patient has adequately responded, you can move from these boluses to maintenance fluid. Maintenance fluid, obviously, it's calculated by weights. I hope you all know the 4-to-1 rule. So depending on the weight of the patient, you can calculate the appropriate maintenance fluid. What's different about maintenance fluid in children is you need a lower concentration of sodium and more glucose. So the preparation of maintenance fluid, you should always give consideration to have higher amount of glucose for pediatric maintenance fluid. So other than fluid, during this resuscitation time, what things should be considered? So another important thing is patient's NPO status. These children are obviously going into surgery. You should keep them NPO, right? But additionally, if these patients have some sort of obstruction, patients have vomiting, they would develop aspiration, right? This is one of actually the things that is making us lose our patients, especially the neonates, is aspiration. So nasogastric tube insertion would decompress the abdomen and would prevent this repeated vomiting and aspiration. So in neonates, you can use an 8-inch feeding tube. In older children, you can increase the size of the tube and decompress the abdomen in those children. So another consideration is antibiotics. So patients where they have an obvious infection or like a gangrenous bowel like this, you might start antibiotics right away. So it's therapeutic antibiotics. If it's started early, it's very essential in the management of sepsis. So you should consider that this patient need antibiotic or not. Another consideration is blood. So not all patients need blood. Obviously, if the patient, if you've been resuscitating them and not responding to your resuscitation, you've given 3 bolus of fluid, then you might consider blood. But otherwise, when you give blood depends on the CBC. So in any surgical patients, initially, simultaneously while you're doing your evaluation resuscitation, you're going to take a blood sample, right? At least you would get a CBC and a blood group. So it's during that time you'll find out the hemoglobin results. So if the patient is not going to surgery, you don't need to transfuse unless the hemoglobin is very low, less than 7. But if the patient is going to surgery, the hemoglobin at least has to be above 9. So if it's below that, you have to transfuse preoperatively. And if the patient is septic, it's recommended to keep the hemoglobin above 10. So if it's below that, you transfuse. So when you transfuse, you usually transfuse 10 ml per kg, and then you might repeat the boluses as needed. So for fluid, 20 ml per kg, for blood, it's 10 ml per kg. And always keep the hemoglobin in mind. If the hemoglobin is normal, if it's above this tolerable range, if above our threshold, then you can prepare blood and go into the operating room, but you don't necessarily need preoperative transfusion. So you've done all this. So when do you say your resuscitation is adequate? So there are different endpoints that you assess. Obviously, the things that you saw initially, the vital signs and so on, have to be improved. But one of the most important things that you have to focus on when evaluating the effectiveness of your resuscitation is the urine output. So it's very essential to follow the urine output. You should insert a Foley catheter in any type of patient that you're resuscitating. Well, in children, Foley catheter is not widely available, the small size ones. So you can use feeding tubes. We usually catheterize neonates with 6 French NG tube and older children with 8 French NG tube. So you can follow the urine output, and you say your resuscitation is adequate when, you can see in this picture here, when you have light urine with adequate volume, we can say you have adequately resuscitated them. But what is adequate volume is again another question, because, well, for adults, you can consider a urine output of 0.5 ml per kg per hour to be adequate. That's your target to say it's adequate. But for infants, you need at least 1 ml per kg per hour. And for neonates, you need at least 2 ml per kg per hour urine output. So that should be also considered when you say resuscitation is adequate. So coming back to this child, the blood count was normal, and he was resuscitated until he had a good urine output, and his vital signs had improved, and we inserted NG tube and antibiotics were started. But then now, if you have the capacity to handle this type of cases, you operate them. But many times, you need to refer these patients, right? Some need specialized care, some might need ICU, and even pediatric surgeons are not available widely throughout the country. So how do you transfer them safely is another question. So safe transfer of children. First of all, the child has to be in a stable condition. All these things that we talked about resuscitation, they have to be finished first. So just because you don't have the capacity to manage those patients doesn't mean you'd send them right away. Even if it's a health center, even if it's a clinic, you have to do the basics, like inserting IV line, resuscitating, inserting NG tube. These basic things have to be done in any primary care center before referring the child. So if you refer the child without stabilization, then the child will obviously die during transport. So it's very dangerous, and it has to be emphasized. The patient has to be stable before transfer. Then during transfer, some complications might happen. One, the patient might go into shock again, right? So you have to be sure that your administration of IV fluids is continuing during transfer. So you have to have continuous administration. And patient can develop different complications. They might become apneic, hypoxic. So having a healthcare provider is, if possible, that would be advised, because this, especially for the smaller children, for the neonates with surgical conditions, they're usually very critical. Another thing the main thing that we fear is hypothermia. So hypothermia is a problem in children, especially in neonates. And this problem is very, exaggerated when we're transferring patients. So on transport from, the hospital to the ambulance, inside the ambulance, and then again to the other hospital, we should always make sure that these children are well. So it's good to check for hypothermia. You can use a thermometer to check, or you can check the skin temperature, whether it's cool, whether there is shivering. And even sometimes vital sign derangements like bradycardia, bradypnea might be associated, might be because of the hypothermia. So we should be able to make that association. But in general, we don't have to wait until hypothermia happens. We have to prevent it. So we need to keep these neonates warm at all time. So how do we do that? As much as possible, we wrap them, but just making sure not to, obstruct their nose and their breathing. So we have to wrap them. This will minimize insensible doses. Another thing we can do is we can use warmers, just portable warmers, radiant warmers, but we know in our situation that's usually not available. So what we do is at least we can warm IV bags. So we have this 1 liter saline bags. We can take 2 of these 1 liter bags and warm them, and then we can place them on the side of the child. So this is a simple thing that we can do that will keep the child warm during transport. Another thing we should not forget is the head is the largest part of the child, when you see the body surface area ratio. So they can lose a lot of weight through there. So it's always, you should cover the head, and you can use cotton and plastic to cover the head to minimize the losses from that area. And other special considerations should be made in some congenital anomalies. For example, patients, neonates who have obstruction, if you keep them lying down, they will aspirate, like I said before. So inserting an NG tube, is good. But additionally, you also have to position them. It's good to keep their head slightly up. If you're holding them, you can elevate the head. Or if they're lying down, you can put a pillow under the head so they're, slightly upright. So this will prevent the aspiration, even if there is vomiting. Patients with abdominal wall defects, so it can be gastroschisis, patients with extrophy, any bowel, bladder, any viscera exposed, you should cover that during transfer. But how do you cover that is a question. So the aim of the cover is to, prevent damage from, environmental contact from different things. But, mostly we see, as professionals cover it with gauze, thinking that the gauze is sterile, but the gauze actually, damages the mucosa. So what we recommend, it's better to cover it with plastic. You can use an IV bag or a urine bag or any type of clean plastic for that matter that is commercially available. You can wrap it around the abdomen of the patient while you send the patient to the hospital you're referring to. So that's one special consideration for children with this special anomalies. So just coming back to the case scenario I discussed in the beginning. So this child was resuscitated and then operated. The part of gangrenous bowel was resected, and we were able to close the abdomen and do a stoma. And this child was severely septic, so we needed to treat him, and he had developed malnutrition, but ultimately the child, survived and is still alive to this date. So I just mentioned this here because just to show you that this kind of patients can survive, and they do survive, because it's difficult. The management is complex. We don't have some of the advanced things that are required, that are written in textbooks, but those are not the most essential things. The most essential things are the resuscitation and the hypothermia management and the sepsis management. If this is adequately done, even in low resource settings, if you aggressively do these things, the resuscitation part, these children can survive. So that's it for the first part. We can take a pause here, and if there are any questions, we can discuss. Anyone wants to reflect things before we move on to the next section.
Okay, Doctor, we have one question forwarded on the Q&A. I'll read it out loud. In safe transfer portion of speech, You said we have to consider hypothermia, and you mentioned shivering. Is neonate experiencing or use shivering mechanism to prevent hypothermia?
Okay, thank you for the question, Melissa. You're right, neonates don't have the capacity to shiver. That's actually one of the adaptations for hypothermia, but this presentation is not specific for neonates. I'm talking about children in general, but I'm in the middle mentioning some specific things about neonates because those are the most critical patients, the surgical neonates. But otherwise, you're right, neonates don't shiver, but the older children can, in the older age.
Okay, super. So the other question is conservative management for gastroschisis.
Okay, so we'll come to management of abdominal wall defects in the second part, but what do you mean by conservative management? Gastroschisis, conservative management, there is, non-operative management, but ultimately these children will need surgery, some sort of surgical closure. So gastroschisis as a general rule is a surgical emergency. You cannot manage them, it's not good to manage them in a center where pediatric surgeon is not available conservatively. They need surgery at some point.
Okay, thank you. We have one more. What is a 4-to-1 rule?
Okay, so the 4-to-1 rule is, for maintenance fluid, you can calculate maintenance fluid by weight, and then you can, so if you calculate per hour, you have for the first 10 kg 4 ml, and for the next 10 kg 2 ml, and for the next kg 1 ml. So that's the 4-to-1 rule. So it's just calculation of maintenance fluid.
The next one is, do you recommend pressors after 2 rounds of glutes?
Sorry?
Do you recommend pressors after 2 rounds of glutes?
Yeah, well, it depends. So if you're talking about, septic shock, and the condition of the patient also matters. There is, you can start pressors, but usually if these are the surgical patients with some sort of fluid loss that you're going to go into surgery and going to operate, usually when you resuscitate them, they would respond, and then you'll be able to go to surgery and fix the problem, and the improvement will continue if you focus on that line. But yeah, at least with 3 boluses, if they don't respond, you should consider that. Sure, I can address maybe 1 or 2 questions I see here.
Okay.
So how to make half-strength saline. So this might be beyond the scope of this topic. Might be too detailed. So some things that you have to read on. But generally here, what we do in Ethiopia is at least we make it 1/3, 2/3, right? So we make it 1/3 of the normal saline and mix it with 2/3 of the. So you calculate the maintenance fluid first. 1/3 of that calculation would be normal saline. 2/3 of that calculation would be 10% dextrose. Again, 10% dextrose is not available, so how to make that 10% dextrose would be another issue. So I think it's a bit more detailed for this discussion. So, but it's something you should read on. And then there's one question about why don't we use gauzes when transferring a patient. So to cover, patient, so the gauzes I'm talking about is to cover exposed bowel and bladder patients with, abdominal wall defects. So even if you make the gauzes wet and cover them with that, it will become dry and it will desiccate and it will traumatize the bowel. So in order to avoid that trauma to the exposed bowel or bladder or any viscera, it's better to use plastic covers rather than gauzes.
Let's go to the second part and we'll address the rest of the questions at the end of the webinar.
Okay, second part, I'll quickly highlight some of the common conditions, emergency abdominal conditions, and how to manage them very briefly. So first of all, we have, these abdominal wall defects. These are congenital conditions. Gastroschisis is one of the common ones that we've already seen in the first case example. And we also have omphalocele, which is another type of abdominal wall defects. So, but this abdominal wall defect, both the management is very different for the two of them. So it's important to properly diagnose which one of the defects it is, because some of them might not need referral for pediatric surgery. So let me give you another example of another patient that we had. This is a newborn who was delivered with a spontaneous vaginal delivery, and he was sent to us on the 12th hour of life for a defect in the abdominal wall. Otherwise, the child looks, is feeding well, and he has normal vital signs. So the parents' only problem was this defect. So you can see in this picture here, it's different from the previous one, right? There is a membrane covering it, but still there is bowel protruding through the abdominal wall defect. So this is what we call omphalocele. The major difference between omphalocele and gastroschisis is, like I said, the membrane covering. So you can see patients with omphalocele, they have a covering of the bowel, but in gastroschisis, the bowel is exposed, and this makes it vulnerable to external damage. So what is the difference between these patients? When you see patients with gastroschisis, they have problems with the bowel. They might have some associated necrosis or atresia of the bowel, but otherwise the childs are healthy. They don't have other associated congenital anomalies. They might be preterm, but other associated anomalies usually not common, other than the bowel problems. In omphalocele patients, usually this bowel is covered with a membrane, so you don't have problems with the bowel, with motility and bowel function and such. But these children usually have other associated anomalies, especially chromosomal anomalies. They can have cardiac anomalies and sometimes neurologic defects. So these patients, although this might not be life-threatening, the cause of morbidity would be the other chromosomal and especially cardiac anomalies. So you have to screen these patients for those conditions. Like I said, gastroschisis is a surgical emergency. So you have to cover this bowel, whether through a plastic cover, or if you are able to close the abdomen surgically, you need to close the abdomen, but it's a surgical emergency. When we see omphalocele, the management really depends on the size. Some of them, they don't need urgent closure. So that's why we'll discuss more on omphalocele here. So when you see omphalocele, there are different types of omphalocele. Omphalocele by itself has a wide spectrum of presentation. So you can have the small omphalocele, we call omphalocele minor, with a small defect. The picture on the right that you see here. So the defect might be very small, and the protruded bowel might also be very small. These are the children that need surgery because this has a risk of becoming obstructed. And these patients usually will recommend referral to a pediatric surgeon, or a surgeon is capable of closing this defect. What about the large ones? The large ones, technically, it would be difficult to close. Additionally, they don't have any risk of obstruction. Usually, these children will be stable. So the main thing that we want to do is to prevent perforation of this membrane. So keeping this membrane intact, making it hardened and epithelialized is the main thing. So that's why for the larger omphalocele, we use the conservative paint and wait approach. So this is actually what was done for our case that I gave as an example here. So you can see the membrane is becoming hardened now. We are painting it with GV. So 1% genital violet, GV is widely available, it's very cheap. And for omphalocele management, we found it to be very safe and effective. So if the defect is not very small, for any medium or large size defect, you can just use, a gauze, soak it with this GV and apply it on the omphalocele defect. You can change the dressing daily. You can do this for a couple of days and see the change. And you can also instruct the parents to do this at home and discharge the parents with this management. And after a couple of months, usually this will be completely epithelialized and covered with skin. So this is a conservative management that's easy to do and does need referral. So if GV is not available, you can use other chemicals too. They're listed here in the slide, but usually it's the most available, and we found it to be very effective in many children. So the thing, the point I'm emphasizing here is we sometimes find patients are referred where they don't need referral. So these patients, if you're able to diagnose them properly, you can manage them even in a setting where a pediatric surgeon is not available. You can just paint it and see, and unnecessary referrals can be avoided in this case. Okay, the second common conditions again in neonates is intestinal obstruction. So intestinal obstruction, when you have any neonates, when you have these signs, you should have a suspicion of intestinal obstruction. So if you have a patient and a neonate with bilious and vomiting, it's a surgical condition unless proven otherwise. Unless you rule it out, you should consider surgical causes, especially malrotation. So patients with abdominal distension, patients who have failed to pass meconium in the first 48 hours of life. So patients usually pass meconium in the first 24 to 48 hours of life, but if it's prolonged, one of the things that you should consider is patient has some sort of intestinal obstruction. So I'll give you another example of a patient that we had. The patient came to us on the third day of life. He was delivered somewhere else with a spontaneous vaginal delivery, and the patient was, the mother was discharged on the same day. She was feeding him at home. Initially, the child was okay, but gradually he developed abdominal distension, which was increasing, and then vomiting came, which became more prominent. And then she also said he has not passed meconium. And when it came to us, as you can see in this picture here, he was very critical. He was very pale, cold, tachycardic, in severe respiratory distress. So this patient was very septic and in shock when he came to us. So you can see from this case, he had all the signs of abdominal and intestinal obstruction, the distension, the vomiting, not passing meconium. But you don't necessarily have to have all these three together. If you have one of them, you should not suspect the child might have some sort of obstruction. So to discuss about intestinal obstruction, one of the most confusing manifestations is vomiting. So vomiting, and especially regurgitation, is common in small infant and neonates, and it's commonly caused by non-surgical causes, right? But if the vomiting is bilious, you should always consider surgical causes. So sometimes it might be difficult to differentiate what's bilious vomiting, what's normal, vomiting without bile, because sometimes it might be lightly stained, might not be this dark green always when it's bilious vomiting. So this picture here illustrates, what we consider bilious vomiting. Those children really need surgical evaluation. Then bilious vomiting, if it's not associated with other signs of obstruction, maybe it might be a medical cause. So you have different medical diagnosis for non-bilious vomiting, but the one exception where you have non-bilious vomiting in surgical obstruction is pyloric stenosis. And in these patients with pyloric stenosis, even if the vomiting is non-bilious, usually it's very frequent and very, aggressive projectile vomiting. When you have that kind of persistent vomiting, even if it's non-bilious, you should consider pyloric stenosis and you should investigate on that time. This pyloric stenosis, however, is not a congenital anomaly, it's acquired. So it usually takes a couple of weeks to develop. It's not present immediately at first. Usually happens after the second week or so. So like I said, you have different medical, surgical differential diagnosis, but even from the surgical diagnosis, you have different congenital and acquired conditions. It's not really that much important to differentiate them as congenital and acquired, but more differentiating them as proximal and distal intestinal obstruction. Because in children, it's difficult to differentiate on X-ray whether this is small bowel or large bowel, but at least you'd be able to differentiate whether it's a more proximal or a high intestinal obstruction or a low intestinal obstruction on X-ray, and we'll see how to do that later. But generally, the thing is that the most serious type of obstruction is volvulus. So malrotation with volvulus is the most disastrous type of obstruction, because volvulus, as you know, not only obstructs the bowel, it also compromises blood supply. So these patients will rapidly develop gangrene. So this should be top on your differential, especially in a child with bilious vomiting. You should rule that out first. The other diagnoses are arterioles can happen in different parts of the intestine, starting from the esophagus to the anus. So all those different types of arterioles can be the cause. We have Fishman's disease and meconium plague, meconium ileus, different differential diagnosis. So when you examine this child, you can rule out some of these differential diagnosis. So for your abdominal examination, you do your inspection. On inspection, you see whether there is distension present. But another important thing that you can do is you can check whether there are hernias present, right? So congenital inguinal hernias are common, especially in male children, and this can also be one cause of obstruction. So that's something to look for on your examination. On percussion, you can differentiate whether this distension is due to bowel or some other mass, because if it's obstruction, you'd expect tympanic to percussion. But children can have different causes of abdominal masses, congenital abdominal masses. It can be a huge hydronephrosis. It can be a congenital tumor of the kidney. It can be some mesenteric, cystic masses or lymphatic malformations. So again, even though it's not as common as intestinal obstruction, this is something that you can check. When you palpate them, you can see whether it's tense or firm or not. And it's difficult to appreciate in small kids, but you can also, see whether there is peritonitis, some tenderness or not. And always, you should not forget the rectal examination. So the rectal examination might be the most important part of the examination of this abdominal examination. And in neonates, the things that you most want to see is you have to inspect for the patency of the anus. You have to see if there is an anus or not, because many children might have anorectal malformation as a cause for this obstruction. It's not only that you see an opening on the perineum, you also have to insert a thermometer inside and check whether it's patent, because sometimes it might look like it's patent, but it might be stenosed or it might be blocked a little higher up. So you need to insert the thermometer and check the patents. So coming back to the case I described, this child actually had no anal opening, but there was a small opening on the perineum that was covered with skin. And we diagnosed this perineal skin-covered perineal fistula, and we were able to do a cut-back canaloplasty at the bedside with local anesthesia, and the child was decompressed. The child was very septic. He required antibiotics for 2 weeks, but he made it. So I just brought this case here to illustrate that this case could have been diagnosed simply and managed simply, but because of this delayed presentation, the child was actually very septic and was about to die. Actually, these anorectal malformations, this should not only be examined, on neonates who developed obstruction, but any newborn before, discharge. If the child is born at a health facility, you need to check on some things. And one of the things that you do on newborn screening is check whether the anus is patent or not. So this should be part of the standard evaluation so that patients will not come back with this type of complication. So what about the children, who you don't find, specific things on physical examination with anus is patent? Then you have to, do some investigations, right? And the first workup for obstruction, intestinal obstruction, is an X-ray. So in children, I don't know why many people order ultrasound for all abdominal, complaints, but if you're suspecting intestinal obstruction in neonates, that's the first thing you should order is a plain abdominal X-ray. So abdominal X-ray would show you signs of obstruction, and I'll show you in later slides how to differentiate between a high intestinal obstruction and a low intestinal obstruction. Additionally, these patients, especially if they come late after 2-3 days, they might also have perforation. So on this X-ray, you can also see if there is only free air under the diaphragm and some perforation. So you can see in this slide I brought here, it is a unit with a perforation. So usually these X-rays are enough for us to go into surgery. But sometimes if the patient is stable, and if the symptoms are intermittent and you have time to investigate, you're not sure of the diagnosis, you can order some contrast studies. So Bahrain follow-through can be done. to see some of these anomalies, especially malrotation. You can see with that if the patient is not significantly obstructed and the vital signs are deranged. Ultrasound, like I said, is important if you are suspecting pyloric stenosis. So in those specific conditions, you can send ultrasound. So just to show you some pictures of what a high intestinal obstruction look like. So when we say high intestinal obstruction, the obstruction is somewhere in the duodenum, jejunum, or very proximally. So in these patients, for example, in the duodenal obstruction, classically what you'll see is the double bubble sign. So you have two large air bubbles. One is the stomach and the other is the duodenum. So the bubbles are large, but the number is few. So that's what makes it a proximal obstruction. In a patient with a jejunal obstruction, you might find maybe 3 or 4 uh, air bubbles on the extra. So these patients, you would consider a high intestinal obstruction. The other condition is malrotation. Malrotation usually causes a high intestinal obstruction. Usually does not have a specific, X-ray feature. It can present, like a duodenal obstruction or other high intestinal obstruction. But like I said, if the patient is normal and you're able to investigate if the symptoms are mild, then you might do a contrast study or parainfluenza. So it will give you this picture like this. So normally you expect to find the duodenal junction on the left side. On this patient, it would be on the right side of the abdomen. And if patients have developed volvulus or twisting, then you'd see this corkscrew sign on the contrast study. What about the low intestinal obstruction? For the low intestinal obstruction, then it will be the reverse, right? So these air bubbles are very small in the low or the distal obstruction, but they are very multiple and they fill the entire abdomen. So these patients you suspect to have obstruction more distally in the colon. So differential diagnosis for these conditions are like Hirschsprung's disease, meconium plaque, meconium ileus, those kinds of things. So why is it important to differentiate these high and low intestinal obstructions? It's because their management is different. When you see the high intestinal obstructions, proximal ones, almost all of them, they require surgery. They are surgical cases, so there is no place for conservative management. But when you see these low intestinal obstructions, some of them can be managed with contrast enema. And yeah, so not necessarily contrast, but you can insert a rectal tube and do enema. So when you have an X-ray with this kind of features and the patient is stable, you can insert a rectal tube. You can use a 20 French Foley catheter, or if that was available, maybe an 18 French NG tube can be inserted, and you can give small amounts of enema, 20 ml up to 60 ml enema, and then you can see whether there is a response. If patients have meconium plaque, meconium ileus, these patients might respond and they might actually improve and don't need any further treatment. Patients with Hirschsprung's disease might also improve, but the symptoms will recur again and again, and ultimately they might need surgery. But doing this will give you time to investigate more to stabilize the patient. So that's how differentiating between a high and a low obstruction is important for the management. And finally, we have acute abdominal nodal children, right? So abdominal pain is a very common symptom in children, and it's usually an unspecific symptom. It can be found in many conditions. Most of these conditions are mild medical conditions which are self-limiting. Patients with acute gastroenteritis, constipation, those children can have abdominal pain. But also, abdominal pain can be a symptom of these surgical conditions. And usually, physicians might not consider these surgical conditions. And when patients come with these surgical conditions with abdominal pain, they're usually misdiagnosed and mistreated, like with antibiotics, and they would come, very late with complications. So it's important to differentiate the medical causes of abdominal pain from this acute abdomen, especially in the younger children. So the final case example that we have for acute abdominal children is this is a 3-year-old girl who presented with a sudden onset of abdominal pain. Pain started overnight while she was sleeping, and it gradually worsened, and then she developed vomiting, and her parents started to notice there was a slight abdominal distension. So they brought her on the immediate next day. So it's abdominal pain that woke the child up from sleep. It's usually a severe type of abdominal pain. So, like I said, you have to differentiate between surgical and non-surgical causes. So, the abdominal pain. And when you look at the surgical causes, appendicitis and intussusception are the common cases that we see. So you have to keep those top in your mind, especially in older children older than 5 years. We have to consider appendicitis. Smaller children less than 5 years, intussusception is more common, but there is no age limit. Both can happen in any age group. That's the trend. But there are also medical causes like I said, gastroenteritis, mesenteric lymphadenitis. Sometimes even patients with UTI with pyelonephritis would, confuse you with a patient with acute abdominal. They come with severe pain. So it's your physical examination that's the most important thing to differentiate these things, and the abdominal tenderness, so thorough examination and able to elicit, the genuine tenderness if it's present is what will, help you differentiate between surgical and non-surgical pathologies. Additionally, you have ultrasound, which will aid you in your diagnosis. So I'll just mention a few points on appendicitis and intussusception, which are the two common causes of, acute abdominal in children. Appendicitis is inflammation of the appendix, which is, attached to the cecum, so it's located in the right lower quadrant. And intussusception is telescoping of a bowel into another part of the bowel. Usually, the ileum would telescope into the cecum. So you would find patients might have some sort of small bowel obstruction. But also with intussusception, the blood vessel also goes together with this bowel. So if you don't treat it early, the patients will develop gangrene. So that complication would happen. And with appendicitis, it's already infected. If you don't treat it early, it will perforate and the infection will spread. So those conditions, if not diagnosed and treated early, would lead to sepsis, especially, after 2-3 days, patients would be very critical. So the common signs and symptoms when you see both, the main complaint would be abdominal pain. That's the different types of abdominal pain. The appendicitis, you'd have, the classic thing is that initially the patients will have generalized abdominal pain, but then it will localize more on the right lower quadrant, and the pain is severe, and it will gradually worsen over the first 1 or 2 days. When you see intussusception, it also has a typical pain pattern, which is also sudden onset severe pain, but the main thing is it's episodic. So the pain happens, and then you have maybe 20 minutes or so where the child is normal, and then the pain will start again. So when you have this sort of episodic intermittent severe abdominal pain, we should consider intussusception. So the child usually might be a small child. Those are the ones that get diagnosed with intussusception. So they might not tell you that they have abdominal pain, but they will cry, they will be very irritable, and they will be inconsolable. Their crying will be inconsolable, and they will draw their legs up towards their abdomen. So that would give you a clue this child is having abdominal pain. Other associated symptoms for appendicitis, usually these patients have some sort of fever and anorexia associated with it. Additionally, they might have a vomiting. And intussusception patients, they can also have vomiting. And in late cases of intussusception, the obstruction will become more severe, so they will have less vomiting. And ischemia will also develop, like I said, so they will have blood in their stool. And additionally, in these patients, usually it's associated with a viral infection. So they might have some history of upper respiratory tract infection or gastroenteritis in the past 1 to 2 weeks before the symptoms started. So having all these, symptoms in mind, you can have an idea of what the diagnosis is, but ultrasound will definitely help you in being sure in your diagnosis. Different signs for appendicitis can be seen on ultrasound. Additionally, ultrasound is important to rule out other gynecologic differential diagnosis, especially in the older female patients. In the around the adolescent age group, you can have different pelvic infections, ectopic pregnancy. You can have ovarian cysts, which can have torsion. So you can rule out all those differential diagnoses with ultrasound. Also for intussusception, ultrasound will be pathognomonic. You can see this target sign or bullseye appearance. And it's difficult to miss intussusception with ultrasound, so it can usually be diagnosed there. So when we see the management of intussusception, appendicitis, usually these patients need appendectomy. There are some controversial cases of these patients presenting late with appendiceal mass, but as a general rule, usually these patients, undergo appendectomy, right? But for intussusception, the management is not that straightforward. So there are two different classes of management. You can have the operative and non-operative management. So previously, most of these children used to undergo surgery, but now surgery is only done for a limited number of patients. We do surgery only if we suspect the patient has gangrenous bone. So if the patient is very septic, has a tenderness or any sign that we suspect the patient has gangrenous bone, we need to do surgery. Otherwise, the other indication to do surgery is if we fail with the non-operative management. Otherwise, the non-operative management would be our first line. So when you see the non-operative management, it is a radiologically guided reduction. You can use the different radiology methods like ultrasound or fluoroscopy. So we, as well as in many other countries, the preferred method is ultrasound. So this can be used, so patients don't have gangrenous bowel if the presentation is relatively early, if the child's condition is stable after resuscitation, then you can do this radiology guided reduction. And the thing that you can do is you can insert a Foley catheter in the rectum and you can instill saline, and then that would gradually reduce the intussusception. So this was what was actually done for this patient. You can see in this picture here, the radiologist would be doing the ultrasound, following the intussusception, the location of the intussusception, while another person might be needed to hold on to the legs so that the child won't move away. And then a Foley catheter would be inserted in the rectum, and saline enema would be administered. So the saline enema would be hung at an appropriate level or height to maintain the pressure. And then the ultrasound technician or the radiologist would see the fluid reducing the intussusception. So ultrasound is very essential for this procedure because one, you'd be able to see whether the reduction was successful or not. And the second one is the fear complication with this, non-operative reduction is you might perforate the bowel. So if there's any perforation also, that would be quickly picked up by the ultrasound. So always when you do this procedure, it has to be ultrasound guided. But it's usually easy, and in it can be done in a few minutes and effective. And the patients also recover quickly. So as early as 6 hours, you can discharge them. So you don't even need to admit them. You can observe them in the emergency for at least 6 hours, and then if they are stable, you can discharge them. So that's all for part 2. I tried to mention the most common special conditions for each of the common causes of abdominal emergencies. So if you have any more questions on this topic and from the previous topic, we can discuss. If you want to further read on these topics, I have listed different references here. You can go into detail. Thank you.
Thank you, Dr. Samuel, for your very informative and organized presentation. We have post-webinar quizzes. The link will be posted, and we'll give our attendees 10 minutes to be done with the quiz. Then after, we can discuss on the questions forwarded on the Q&A in the chat box, and we'll also discuss on the quiz questions. Okay, time is up, so the quiz will be closed now. Dr. Samuel can address questions.
So the first one, it says, we're saying we have to resuscitate the patient first, but also the underlying problem can cause an irreversible problem. Is there any way we can do both together? Yes, well, obviously, you try to do things simultaneously as much as possible. I'm just trying to emphasize, on the importance of resuscitation. You should give priority for resuscitation. So the definitive management for most of these conditions is surgical management, and you cannot go into surgery without adequately resuscitating the patient. If the patient is not adequately resuscitated, if you start with your surgery, the patient would go into cardiac arrest. So it's just to emphasize on the priority. Otherwise, as much as possible, you can do things simultaneously. The second question, what is the reason behind unit output of neonates being greater than that of infant and children? Well, it's all has to do with the physiology of the children. It's different. Like I said, the vital signs are different for children and adults, depending on the age group, right? So the renal physiology is also different. Their ability to concentrate urine is less, and they cannot process sodium as much as the adults. So that's why, on the maintenance fluid, you give less sodium. When you assess the endpoints of resuscitation, you should consider that the urine output is more. And also, when you give maintenance fluid, you have to give more dextrose containing solution. So it all has to do with the different physiology in smaller children. Third question says, what's the difference between 0.45 and 9% normal saline, and how effective is it for pediatrics treatment? Well, like I said, for resuscitation, you give 0.9% normal saline bolus. Always resuscitation is normal saline, no added dextrose, not 0.5% has to be isotonic. But for maintenance fluid, for us, we don't have this prepared with 0.45%. So we have to mix different things and create our own fluid solution. But what's recommended is for the smaller neonates to have 0.5% saline mixed with dextrose for maintenance fluid purposes. But if not, like I told you before, we can mix the different types of fluid that are available to create this. Fourth question says, what if they have malnutrition? Do we still use a 4-to-1 formula with that? If it's moderate malnutrition, then yes, you can go ahead. If it is patients have severe acute malnutrition, it's very difficult, especially if the patients are going emergency surgery. If it's elective surgery, we try to rehabilitate them nutritionally as much as possible. But if they are undergoing, emergency surgery and they are in shock, you have no option. You have to give them fluids. But you have to be careful when you give these children fluid. So the fluid type is different. Also, you have to be slower. You cannot give them aggressive fluids. And in general, you want to hydrate them PO as much as possible. You don't want to give them IV fluids. But if you need to do it, if the patient is in severe shock, then you have to do it. But you have to be careful how to do it. Fifth one, why was stoma indicated in this patient? Wouldn't it add to the nutritional burden? Yes, well, the patient, I assume you're talking about the first case, which had a gangrenous spot. Obviously, we needed to resect that gangrenous spot. But then the next question is whether we should do anastomosis or a stoma. So that's always difficult. In neonates, we try to avoid stomas, especially ileostomy, as much as possible, because it will have a high output, and then patients will usually go into, repeated dehydration, electrolyte imbalances, and malnutrition. So we try to avoid it as much as possible. But also, when you see the condition of the patient, closure of the abdomen will be tight. The bowel is already contaminated. So if you anastomosis, it might, get infected, it might leak. So having all these considerations in mind and keeping in mind that it's difficult to close the abdomen, that's why we did a stoma. But yeah, it's a difficult decision because we don't have parenteral nutrition. If the patient develops a high output stoma, it will be difficult to manage after that. 6-1 says, can we consider pushing back the exposed bowel to prevent necrosis when immediate surgical treatment is not available? Well, yes, this hospital actually, before they referred to us, they had called and consulted us about this case. One of the things that we considered is the defect might be too narrow and it's compromising the blood supply. So we told them to widen the defects by cutting the defect and making it more wider, the abdominal defect. But pushing it back would be difficult because one, the abdomen will not allow you to accommodate all that power, and also you might be, adding more pressure on it. So rather widening the defect would be what they can be done. But in this case, it looks like the gangrene happened, even intrauterine. So we were not able to reverse it with that. 716, are there congenital adhesions? Yes, congenital adhesions or bands can happen. They can be associated with some malformations, some remnants of, like the omphalomesenteric ducts is an uh, embryonic structure. Sometimes it might have a remnant, sometimes it might cause a band, which causes obstruction. Patients who have malrotation can have different types of bands going from one part of the band to another part or to the abdominal wall. So this can also be a cause of obstruction in neonates. Sorry, Dr. Malik, by the way, I'd like to introduce Dr. Caroline Stephens from UCSF. She is here in the chat with us. She's actually one of the collaborators who was instrumental in developing this training. So I'd also like to invite her in if she has any comments on answering the questions too. Okay, in the meantime, I can go through the other questions. Is there a risk for necrosis of small size omphalocele due to strangulation effect? Well, for the small omphalocele, I haven't seen them strangulated, but I've seen them obstructed, patients coming obstructed. And some of these patients in a peripheral hospital for these small omphalocele, some have started already this paint and weight management. They have already started painting GV paint on them. And then these children, eventually they will develop obstruction. And then when we tried to do the surgery, it was very difficult because they have already started applying this esclerotic therapy. There were adhesions and it was difficult to close. So that's why my recommendation is if it's a small omphalocele, since there is a chance of at least obstruction, to do the closure. But I haven't seen it being strangulated. 91 says, is there an acceptable negative appendectomy rate with classic signs and symptoms? Is ultrasound a must in suspicion of appendicitis? Well, in adults, like you've seen, we do, because ultrasound is hard to find and it takes time, we do appendectomy without any imaging, depending on the signs and symptoms, but not in females, all right? It has to be at least in males with classic signs and symptoms. So in females, you have to have ultrasound. In children also, it's the same. If it's a female, you have to have ultrasound. Additionally, for the smaller children, I would recommend ultrasound, especially children less than 5 years of age, where the age group where appendicitis is not common. You might have other diagnoses that you might miss. So I would recommend ultrasound in the smaller children and in females in all age group. But in older children, even if they are males and if the signs are classic, you can go ahead without an ultrasound. 10-1, what are the contraindications for ultrasound-guided reduction and direct surgical indication? So like I said, the contraindication for ultrasound-guided reduction is if you're suspecting a gangrenous spot. So how do you know a patient has gangrenous spot? The patient would be, very septic, febrile, tachycardic, and that's not due to fluid loss. So you've given them a bolus, you've resuscitated them, but the patient is not adequately improving. The patient is very febrile. Then the patient has tenderness on abdominal examination. You don't expect tenderness until the bowel has become gangrenous. In early intussusception, you don't expect tenderness. Additionally, the patient might have a leukocytosis, so white cell count would be high. So in all these cases, you're suspecting a gangrenous bowel. Additionally, ultrasound might sometimes also show you the blood flow is decreased. So if you have all this suspicion of having a gangrenous bowel, it's better to go to surgery, because if you do this ultrasound guided reduction on a gangrenous bowel, it will perforate the bowel, so it would be very dangerous. So other than that, if the patient is stable and If you don't see any sign of this, having a gangrenous bowel, usually this is the case in patients who come early in the first 1 2 days, you'd be able to do ultrasound guided reduction. So the indication for surgery is, if you have this gangrenous bowel or if you have failed with ultrasound guided reduction. So the ultrasound guided reduction you can attempt up to 3 times. If you do it 3 times and you fail, you should go to surgery. Sometimes some surgeons you might decide after 2 attempts, if you fail, you can go into surgery. What is a post-op course like in our setup? By post-op course, I don't understand specific for what type of condition you're referring to. I mean, the one who asked this question, it would be good if you can elaborate. 12 can we differentiate neonates with different causes of acute abdomen based on the time of presentation from birth between HPS, duodenal, jejunal, ileal atresia? Yes, the time of presentation will give you one clue because, like I said, HPS is not present at birth. It happens, after 2 weeks of life. It happens. So if it happens immediately at birth, you would consider as a differential diagnosis. Atrasias usually, they are congenital, so you would expect manifestations starting from birth. But sometimes it might not be a complete atresia. You might have a stenosis, so some amount of milk might pass, but there is a stenosis, some degree of partial obstruction. Those cases, even though they're congenital, they might present later. So yeah, it gives you a clue, but not always. It's not definitive. 13 says, what are the most common postoperative complications in pediatric abdominal surgery, and what strategies can be implemented to effectively manage and prevent these complications? Okay, so the common complications, I mean, they are more or less the same complications in adult. You have different types of infections. So wound infection is one common complications that we have. Additionally, you can have pneumonia postoperatively and UTI. And maybe, the other post-op complications like DVT and pulmonary embolism is not common in children because, even though they are immobilized relatively for a longer period of time, especially the small children, they don't form this thrombosis. Otherwise, the infective complications, we have that. And, to manage to effectively prevent these complications, you need to strictly follow the infection prevention control guidelines. How is intraosseous access acquired? So this is, you puncture the medial part of proximal tibia. I mean, you can read more on the details of the procedure, but you puncture the bone marrow and then you administer fluid there. That is the principle of intraosseous access. And it will be good if you have an intraosseous needle, but if not, any bone marrow needle, or like I said, even this transfusion needle can be used in smaller children to puncture the bone. 15, how far should the IV bag be in order for successful hydrostatic reduction? Yeah, so it depends. So we want there to be a certain amount of pressure when we do the hydrostatic reduction. So above the level of the bed, above the patient, at least around 120 centimeter height should be there. So if it is too high, then the pressure would be very high and it might cause perforation of the bowel. And if it is too low, the pressure might not be enough to adequately reduce. So you should maintain appropriate height. Sistine, can you tell us some points about Hirschsprung's disease? Well, Hirschsprung's disease is, it can have different forms of presentation. It's not covered in detail in this CME. So it can present, chronically in older children with constipation, but in some forms, it can present also acutely as an emergency in neonates, as intestinal obstruction in neonates. So it can present chronically with constipation or early neonates as intestinal obstruction. And like I said, the presentation is similar to a low intestinal obstruction. The X-ray will be similar to the one I showed you earlier. And so And when you have that type of X-ray, initially you can insert the rectal tube and do irrigation, and you might have some improvement. So if that's the case, you have time to do different investigations to confirm whether this is Hirschsprung's. So you can have a barium enema, you can have a biopsy, different investigations if the patient improves with enema. So if the patient doesn't improve, you need to go to surgery and do a colostomy, and you can do the biopsy also later to confirm the diagnosis. But Hirschsprung's by itself has a wide spectrum of presentation and needs a detailed discussion in another session.
Sam, if you don't mind, I'm just going to say a few things, I think, also on what you just touched on.
Okay, go ahead, Karen.
It's Caroline. So, hi, everyone. Thank you so much for welcoming me. My name's Caroline Stevens. I'm a general surgery resident at UCSF. I've also been supporting Sam with this work, and it's work that's actually built off some of the work we've also done with running courses in Uganda related to assessing pediatric surgical emergencies. I think the most important thing is we all recognize that these are often very challenging and can be very confusing cases. And that's part of why Dr. Samuel Negash has put together this presentation, is because it can be difficult to assess. There are some small nuances, like I think things to kind of keep in mind is one, if you like Google the 4-2-1 rule, or even what Dr. Negash was just talking about with doing the enemas, there's actually really great YouTube videos on how to do, for instance, an enema for Hirschsprung's disease that gives you specific instructions. We're going to try to make a video as well, hopefully sometime in the future, but there's really great resources on YouTube, I think more than you might expect if you look up, for instance, Hirschsprung's disease and enema. And that's, part of the reason it's highlighted is that that's what's critically needs to happen in order to prevent the child from developing enterocolitis, which can then result in sepsis and ultimately in death. And so part of the reason this talk is put together is because so many of these things, if they're recognized early and resuscitation is initiated, you can save the child. Frequently, a perfect operative intervention can be done, but because there wasn't resuscitation done before, the child is septic, they have aspiration pneumonia, and they may succumb to those things afterwards. The other thing for specifically malrotation, I think often when we envision malrotation in our minds, we think of a child with very, very distended abdomen who looks very sick, who is vomiting, but it can actually present much more mild, and finding it earlier is really the more important thing. So when the child is very distended, that's where they may have had a volvulus and have a lot of necrotic bowel, which will make it very incredibly difficult for the child to survive. But this is part of why there's this general rule that for any child presenting with bilious emesis, it's considered a surgical emergency, because bilious emesis is often the first sign without significant abdominal distension, because they haven't had time. The distension comes basically from the bowel experiencing compromise of blood flow. So if there hasn't been time to develop this compromise of blood flow, they may just have bilious vomiting, but they might not have a very distended abdomen. And these are the patients, again, if they're early enough, where you first get an abdominal x-ray, but you might not see very much on the x-ray, and then you can get a contrast study. But I think the big thing we want to prevent is a very long delay where you wait for the child to show you that they're sick and they have bilious emesis. This is part of why you want to kind of act quickly with bilious emesis. But I think Dr. Negash will share his contact information, and so much of these questions are best kind of dealt with at the time when you're dealing with a patient. That's also the best time to learn, with your colleagues, with your collaborators about these different disorders, is when you're having these questions, and asking, someone who has experience in this area, I think is really often the best way of figuring out, what do I do with the resources I have? How do I make sure this child is safe in transfer, and all of these things. I don't know if, Sam, you have anything else to add on that side.
Thank you, Dr. Samuel and Dr. Caroline. We have a post where the quiz will be shared, and you can discuss.
Thank you. So the first question is about a patient who had, presented with crying, nebulous vomiting, and there was bleeding on the diaper. And when you assess them, patient is tachycardic, and a capillary refill was delayed. So this patient, you can see, has cardiovascular system compromise. He needs resuscitation. So the appropriate first step in the management would be to give them a bolus of fluid. So the option D would be correct. I think half of you have answered correctly. So abdominal ultrasound, abdominal X-ray, all these investigations would come after resuscitation of the child. Okay, even before sending for investigations, you should resuscitate. So D is the appropriate answer. Next question. What is the most reliable indicator of adequate fluid resuscitation? I think most of you answered this. So urine output is very essential. You only know whether you have adequately managed resuscitated a patient if you see they have adequate urine outputs. Okay, shock has resolved when there is adequate urine output, so you should always remember that. Okay, third one. Third one, any neonate with the symptoms should raise high suspicion for requiring surgery, except. So you have bilous emesis is a sign of blood in stool. Also should raise suspicion of obstruction. So it says failure to pass urine and meconium. So like we said, failure to pass meconium, we say it's abnormal if it's more than 48 hours. Okay, for the first day of life or even the second day of life, the child might not pass meconium, a normal child physiologically. So unless it goes beyond 48 hours, you don't consider it abnormal. 24 to 48 hours. So this one only, it's 1 hour. So D would be the appropriate answer. Around half of you have gotten that. The other are all surgical conditions. Some are related to obstruction, some are related to other surgical conditions, but they are all surgical. Final question is double bubble sign. This is a simple one. It's a sign of duodenal obstruction, right? So the answer is B. Most of you got it right.
Okay, thank you again. Thank you, Dr. Samal, for your informative presentation, and thank you, Dr. Caroline, for your detailed explanations. Our webinar today will end here. Thank you for our attendees for joining us. I hope you have grabbed some take-home messages and informations that are very
Sorry,
important in
Malik.
surgical emergencies. Yes, Doctor.
Sorry, Malik, just I'd like to add one point because there was
Sure.
people were interested in intussusception, and as part of this larger training I told you about, we have more detail on this hydrostatic reduction. And I mean, I don't advise you to do it unless there is a radiology or someone trained with ultrasound together with you. But if you have it, this is how it would be done. So you need to hang the saline. So the pressure you need to be 120 millimeter of mercury. So you need to hang the saline somewhere 80 centimeter up to 160 centimeter above the patient. So you hang the saline like this and you administer the enema. Simultaneously, you need to have someone doing the ultrasound. So that's how you do it. And the appropriate height is the most essential thing. But yeah, if you're trained, if you have some radiologist with you, you don't need to do surgery for these patients. Thank you. I'll just end there.
Okay. Thank you, Doctor. Thank you again. And thank you, our attendees, for joining. And thank you, Dr. Samal, for your time. And thank you, Dr. Caroline, for joining us. Have a good evening and have a good day.